Now we'll move on to our first Primary Care Innovation Showcase. This is focusing on the Medicare program. I'd like to invite to the stage Shari Erickson from the American College of Physicians, who will moderate the panel. We also have speakers Sean Cavanaugh from Aledade and Vivek Garg, MD from Humana.
All right, thank you. Welcome to both of you, our panelists. I know that your bios are in the background materials, and Vivek, thank you for joining us. I know there was a change last minute, so appreciate that. And Sean, so I'm Shari Erickson, the Chief Advocacy Officer of the American College of Physicians, and I'm here to moderate the session. And so what I'm going to do is turn it over to both of you to introduce yourselves and your organizations, and then talk a little bit about how you're engaging in the Medicare program.
Hi, everyone. Good morning. Vivek Garg. I serve as Chief Medical Officer for Humana's Primary Care Group, which is almost exclusively focused on seniors. We're called CenterWell and Conviva Primary Care. We're actually the largest senior-focused primary care group in the country. So we have about 250 clinics serving seniors across the country. We serve Medicare patients across different Medicare Advantage plans and also ACO patients. We serve 250,000 seniors right now every day across our centers and across an IPA that we also support. We are all in on Medicare. And part of the reason I joined the primary care group through Humana was the deep focus and consistency around belief in Medicare as an important social and healthcare program, and the meaningful changes that people have talked about here that are possible when you have payment, social policy, and healthcare delivery aligned. And so we are just one part of the puzzle, the group that I'm a part of. Humana's had a very long-standing commitment, not just to Medicare as a plan participant, but also around the enablement of value-based care. And so there are many longtime Humana partners in the room, including Sean's organization, which just signed a 10-year deal with Humana to continue the great work that Aledade is doing. Oak Street, Agilon, health systems, private medical groups, small independent practices. And so as a physician, that was part of the appeal for me, because I think our patients need choice, our system needs the experience around different types of models and approaches, and we need to lift all boats for our patients over time, and Medicare has been a great enabler of that.
Thanks. Hello, I'm Sean Cavanaugh. I'm the Chief Policy Officer at Aledade. Aledade is the largest network of independent primary care practices in the country. What we do is we organize independent primary care practices into value-based entities, and we support them in the transition from fee-for-service to value. So we are all in, not just on Medicare, we're all in on primary care and all in on value. And the way we work is after we organize these practices, we try to get their entire patient panel in a value-based deal. So that means we have a substantial presence in the Medicare Shared Savings Program. I think we're the largest organizer of ACOs in that program. But we also do deals with Medicare Advantage plans. Vivek mentioned our recently announced 10-year deal with Humana. But we're all in on employer-sponsored value-based deals as well. So we're in 45 states, about 1,500 practices spread across those states. Think about 2.2 million lives in value-based deals in these practices. About 1.3 million of them roughly are Medicare, either fee-for-service or MA. About 800, 900,000 are commercially insured, and another couple 100,000 are in Medicaid. So we're trying to transform these practices to provide better care at lower cost, regardless of the source of insurance for the patient, and indirectly to support these independent practices in remaining independent.
Great. Thanks to both of you. You mentioned how many lives, Sean, that you have in your practices. And so I want to talk a little bit about being patient-centered and what it means in the Medicare program for primary care to be provided to that population in a patient-centered manner, and what types of activities your organizations are taking on to ensure that the care that you're providing is focused around the patient. So I don't know, Sean, do you want to kick this off on that one?
Certainly. So, I mean, if you think about it, we've all have been discussing today the plight of primary care financially, is particularly. Chris Kohler earlier talked about a practice that he knew in Rhode Island that's getting paid 70% of the Medicare fee schedule for Medicaid patients. It is very common for independent primary care practices to get 70, 75% of the Medicare fee schedule for commercially insured patients. So these practices are really in financial distress. And unfortunately, there's two reactions to that financial distress. One is to sell the practice to the local health system, which if you had told me 15 years ago, I'd have thought that might be a good move. Unfortunately, the literature now shows that leads to higher costs almost across the board. The other thing they can do is see more patients, right? Get on that hamster wheel of seeing more and more patients, shorter time, which means what? Patients with complications you need to refer out quickly because they're taking up too much time. Seeing well patients is better than seeing sick patients. So what we do that we think is good for the practice, but also, as you say, patient-centered, is to try to flip those economics entirely, which is in a value-based deal, it isn't necessarily the well patient you want to see. Referring out as quickly as possible is not necessarily the prudent move. We teach through analytics, through workflow coaching, we teach our practices to think, who's the patient who's not in my practice today that needs to see me the most, that's most likely to end up in the ED or the hospital? How do I reach out to them and bring them in? Who just got discharged from the hospital? You know, how many of us have gotten a call from your PCP the day after you got discharged from the hospital? Well, in Aledade practices, you do, because our practices know about this and they reach out to you, and we know when they do that, if they bring you in for a transitional care visit, you have a significantly lower likelihood of being readmitted to the hospital. So the patient-centeredness is inextricably linked to the economic model. By moving to value, our practices now can practice medicine the way they wanted to, which is to focus on who are the patients that really need to see me today.
I always agree with everything he says. That's why I took a lot of notes and brought them. I wanted to talk just first about how Medicare enables, I think, patient-centered care, because I think it's important to look at Medicare relative to other payer coverage areas and ask ourselves, what should we replicate or think about in the future? So one is the duration. When you become eligible for Medicare, you're for the most part eligible for the rest of your life. We don't check it again. You're there. You can choose different coverage options. You can choose different providers, but Medicare is there for you. And duration is very important to the long-term investments needed in patients' health and this system of care so that we can be partners with them through that and not have the conflicting financial incentives from a more short-term view. The second part is around the comprehensiveness. And I think this is one of the reasons why Medicare Advantage as a portion of Medicare has continued to grow, which are the benefits. And I know you can look at the benefits and say it's about growth and membership and change, but these are real services for the most part that people need in their life. And we've medicalized them and made them healthcare benefits, but I don't really care. They need them. Transportation, social support, financial assistance, post-discharge meal support, all of these things that are a part of the comprehensiveness and the affordability of people's life and their quality of life and their health. Medicare is the biggest anti-poverty program and the most successful anti-poverty program for elders in our country. So the comprehensiveness of what Medicare provides as a framework, both through benefits, through all the participation in different payer frameworks, government-sponsored or privately driven, as well as the network, as well as the quality framework, these all come together, I think, to support an ecosystem that allows us to potentially be more patient-centered. The last part is the care, which Sean spoke to. And just to parallel what he shared, I think when people get older, what geriatricians tell you is that they become more individualistic. They become more the person they are. They have less tolerance for other stuff and other people. And I've yet to meet somebody as a patient or someone our teams are caring for or my own loved ones who doesn't want to look somebody in the eye and get to know them and feel like they can trust them. They're often in a diminishing social circle. Maybe their finances are difficult. Their family are having other health issues. They're being asked to take 10, 15 medications 2 or 3 times a day. How many people here have tried to take a medication 3 times a day on time? If you haven't and you're not in that situation, I suggest you get a pill box and try it out. Just buy Tic Tacs. Don't take medicines you shouldn't. It's really hard. And just look at 5, 10, 15 medications that people are frequently discharged with. So what I see and what my teams tell me in our primary care group is we want to know our patients and they need to know us. When they call us, they want to know, does the doctor or nurse practitioner know that I called? When they have the relationship with the medical assistant, it's not all about the clinicians. They feel that trust and engagement, and we can be there for them in the way we want to be. So I think personalization of care, seeing people as people, it comes from other people. So a huge part of this is creating the team, as we all know, supporting the team, and giving them the time that was spoken about by Clive and others, and the longitudinal focus and support so that there's that real relationship that we all care about.
Thanks. And you actually dove right into what I was going to talk about next, which is addressing social drivers of health and health equity. And I think it's that came up earlier, as you mentioned, and you spoke about a little bit now. The challenge it is for primary care physicians within their practices to be able to help their patients obtain those sort of community supports, those post-discharge meals, those other, getting, into an exercise program, whether that's on YouTube or going to a gym, whatever that looks like. And particularly when you're talking about Medicare patients, as you talked about, they do get more individualized, very particular perhaps about what they do and don't want to do. So I'd love to hear more about really what you're doing with Humana to actually directly try to support that, as well as you, Sean, in terms of what Aledade may be doing to help these individual patients be able to achieve their goals and address their social drivers of health in a way that, is supportive also of the primary care practice, but doesn't overburden the primary care practice, given that they don't necessarily know where to access all of these or where to advise their patients to access all of these services.
Yeah, our teams care so much about our patients' needs and context. They are so happy and proud when we could provide more for them. Primary care is in the business of doing more for patients. That's what people care about. Humana, I think, has at the start of a long journey that we're all on to really fundamentally address this issue. This problem has been known. I remember being in medical school and going to a public health course and looking at the graphs from Ben Haynes about the disparities in care based on race and ethnicity. This is 15 plus years ago. Fivefold differences in real health outcomes right now for the past couple decades, and then going to a lecture about a 0.5% absolute improvement in some new procedure and benefit. And by the way, they're building a tower about it. And it's funny, I know, but it's also very hard. And I think people who are very deep in health equity have to have a lot of patience. I can understand why they're really frustrated. And I can understand why they're challenged to try to work with all the rest of us who maybe are not as familiar yet about where we need to get to and what are the right next steps. And as people said earlier, we cannot put this all on primary care teams. These are systemic issues that they partner and actor in, but they are asking, what can I do about it? Where will the help come from? So I think Humana has done a number of things, including publishing research about looking at Humana members' performance on preventive care HEDIS measures split out by race and ethnicity, and challenging itself to bring visibility to the issue, obviously thinking about where CMS and CMMI want to go and wanting to be a partner on that. The Humana Foundation is making different grants around working with medically underserved populations, fostering emotional health, supporting nutrition. And we have a great chief health equity officer that we all work with who's playing that role of helping us understand where we are and how far we need to go, but being patient and trying to help us take those next steps. I think when it gets down to the primary care team, it's going to be really interesting because as we build the data pipeline and the visibility, and I've had conversations with others in the organization, what do we do with it? I mean, my teams who are trying to get the social needs screened and addressed, the LCSW therapists who are trying to screen for behavioral health needs, trying to be available in a moment when a patient walks out of the primary care visit and the PCP says, hey, I need you. What are we going to do when we show them these massive disparities and ask them to engage in it? And I'm a little bit worried, not that we will do this, but that the industry will short circuit to incentives. And I think we need to make it real, but trying to drive incentives at the individual actor level is going to be tough. Keeping it aggregated at a community level is going to be too diffuse. So I think finding the unit of action at a community level and thinking about maybe across payers, how do we organize to create more community-based services like Perva and others mentioned yesterday? So I think we need in addition to the conversation about behavioral health, we need a national social work and community health worker core that's payer agnostic, community-based, something we can all be cooperatively partnered with. Those are the types of things I think my team's going to ask me as we start to show them the data, because there's only so much you can fund, even under a full risk primary care model, to extend into these other domains.
Yeah, before I give the specific answer about what we're doing, I just want to highlight that this sort of, the very question reveals the paradox of primary care, which is, on the one hand, you're going to be the least esteemed in medical school. You know, people are not flocking to the field. You're going to be the worst paid when you get out of medical school. But on the other hand, when society has a really important problem, you're going to be the first people we pivot to. Like, if you look, even in the existing programs, Medicare Advantage and others, most of the quality measurement, which are presumably things that we really feel most passionately about, are primary care oriented, right? It's about the management over a longitudinal period of time of multiple chronic diseases, right? The great societal challenge. Well, we're putting that primarily on primary care, which probably should be. The second big societal challenge, equity, social determinants. Where do we pivot almost immediately? Primary care. So one, I do think primary care is going to need a lot of help. I do think they should be front and center. They're going to need a lot of help. At Aledade, we're doing a number of things. One, we are, I think, as I said, we're the largest participant in the Medicare Shared Savings Program. We also, I think, are perhaps the largest organizer of federally qualified health centers in the Medicare Shared Savings Program. And interestingly, in 2021, which is the last data CMS released, 2022, excuse me, the best performing ACO in the Medicare Shared Savings Program was an Aledade ACO that's exclusively federally qualified health centers in the state of Mississippi. So poor rural communities served by federal. And why? I think it's because they've been in the business of caring about, of being connected to the community, connected to their patients for many, many years. With our tools, I think they do better, but I think this is the work they were born to do. Separately, apart from the federally qualified health centers, you know, following George Floyd and others, when Aledade wanted to get into that, really dive in and put our skin in the game on the equity business, we decided to focus on reducing disparities in uncontrolled hypertension among Blacks versus whites in our networks. And we made it not just a goal for our ACOs, we made it a corporate goal. The executive team, our bonuses are dependent on it. And we made some progress. Not enough. We actually, I think this is typical of disparities work. We actually saw improvements for whites and Blacks, but the narrowing of the gap was fairly modest. But we doubled down and we set another goal for this year. So it's hard work, it's the right work, but we're all going to need a lot of support. Primary care is the right field to lead, but again, if we're going to put so much on primary care, they need so much more support.
So, thinking about addressing health equity and disparities, one approach that really picked up the pace on during the pandemic was telehealth and the provision of telehealth. And as you know, we have some flexibilities around that and a payment around that has been extended through the end of 2024 for Medicare. There's quite a bit of variety in how private payers are approaching telehealth across the board. And so I will tell you, as someone who works with a lot of physicians in practice, that's challenging for them to figure out what they can do and what they can't do for their patient population, particularly those, that are older, that may not, even if they have access to a computer, they may or may not know how to use it. They may or may not be able to do audio, video. They may just have to jump to audio only with their physicians to be sure that they're getting the care, particularly for multiple chronic conditions. If they're in a longitudinal relationship, a lot of times these physicians know them, can pick up what's going on with them, and continue that care. Yet we're at a time where there's a real transition happening now, I think, in some ways back to our sort of formal approaches of having to go into the office in many cases, or if telehealth's being provided, there's a lot of different rules that they're playing under within those practices. So I guess I'd like you to speak to a little bit more about what Medicare can do through what you're doing with Medicare or Medicare overall in terms of innovating on this front and ensuring that the Medicare patients are getting continuous care, whether that be in person, whether that be via telehealth or some other mechanism.
Happy to start. Telehealth. It's a painful topic in some ways. I think that So what I hear from our teams is the technology is still not there. And so I would ask, it's not just about seniors. How many of you have had all of your Zoom meetings work for the last year? Nobody. Someone's on double muted. Someone doesn't open the screen share properly. It's all the same stuff. So I would challenge, based on my team's feedback, because we've tried a lot of modalities, that most of what we take for granted is whether it's actually effective or not. And then there's also a portion about technology access, comfort, education, partnership, and making the encounter effective. I think people are actually quite smart about choosing the modality of care that they think is going to serve their need. And I think we've seen that through COVID, and Humana and others have published data. Humana's value-based care report every year does report out on telehealth utilization among our provider network based on the codes that are submitted. And obviously a huge spike in behavioral health access through telehealth. Very important to continue supporting that. Persistent, higher utilization, even as COVID has morphed in different ways. But in the basic primary care level, it's gone back down. And I don't think that's necessarily bad. That's people making choices about how they want to access care, whether they want to be in person. The exam room has a formality and sense of security to it for many people. When I've talked to seniors, many of them actually want to get out of the house when they can. It's a social activity. It's something they look forward to. It's something they plan around until they can't. And so we're dealing with multiple types of needs at different times in people's life journey. From a care model perspective, the microfragmentation and dissonance among what's covered and what you can bill and all of that is really going to hamper our ability to create the flexibility and resilience in the model, which we were just shown we will need. And to the degree that we can all support policy efforts to enable, at the very least, people who own the longitudinal relationship like primary care to have very full flexibility around the modality of how they deliver it, I think we will be better off. And my last quick thought will be around audio versus video. There's nothing new about calling your patient. There's actually a lot of richness emotionally in talking to somebody and just hearing their voice. And I actually see that patients, if they've met you in person, they're okay with a phone call for a lot of things. You can have some really serious conversations by phone call. I've counseled patients into hospice by phone call. We've had family meetings by phone call. We've made significant clinical decisions by phone call. So while I agree that video has a richness to it and potentially some added benefits, I would say everybody who's practicing would tell you that we need to make sure that audio is a persistent feature in the flexibility of our care model so that we can continue the expanded access, especially in areas where there's low healthcare infrastructure and supply for the general needs of our patients.
Yeah, I think Dr. Garg touched on a lot of the important considerations. As a former federal bureaucrat, though, I always go back to telehealth sort of is the quintessential Medicare payment issue, which is someone had a great idea, maybe we could provide healthcare by telehealth, and then everybody swooped in and said, all right, let's think of the 100 ways that could be abused and put then in the statute restrictions on that so it could never happen. And if you read the statute, it's more about what you can't do than what you can do. And having, again, been a federal official and seen some of the actors in fee-for-service medicine, the vendors and the people who crop up when they see an exposure in Medicare payment system, it will be abused if it can be. That's one of the reasons, value-based care offers some solutions, which is in value-based care, I don't know why Medicare cares at all, to put restrictions on an ACO or a group of primary care physicians who are trying to do the right thing. And telehealth's just one, but there's a myriad of Medicare payment restrictions, conditions of payment, conditions of participation, supervision requirements that really don't necessarily make any sense in the context of an ACO or other entity that's accepting responsibility for the whole experience of care.
I think Sean and I are saying if Pervo was still here, we'd ask for an exception for all ACOs and primary care.
Actually, I got her in the hallway.
Oh, okay.
Yeah, no, and I agree with you. And I think what you said about audio only is critically important because that is what I have heard. And there's a great concern about that, the payment for that or ability to do that in a consistent manner going away. And that gets actually, I think what Purvis said too, about being hard to address health equity through fee-for-service. and the importance of really moving to a value-based arrangement to be able to do that. Yeah, did you go ahead?
And I was going to say, if Perva was here, she might be saying, well, I just sort of hinted pretty strongly there's a primary care model coming, which will probably have some form of care management or primary care capitation fee, which in that context, these rules hopefully don't apply at all, right? Like, you're not trying to get paid for the phone call. You're not trying to get paid piecemeal. You're trying to get paid for the appropriate care for your patient.
And I'll just add, as a layperson trying to interpret federal regulations at times, I should probably just call you if you're free. I think we need more statements of affirmation for our provider community and our clinicians and all the people supporting these groups. Often when you read the regulations, to your point, Sean, it tells you a bunch of things you can't do. And that makes everybody afraid that maybe the thing that wasn't specifically identified you shouldn't do, like a phone call, or is it reimbursable, or is it allowed, whether you're under a different payment model versus fee for service. So it'd be great to have more clarity about positive affirmation about what groups can do and should do, and expect that they have the policy support to do it.
I'll tell you a little anecdote on that. When I was at CMS, we created the new billing code for annual wellness visits. Co-payment, it's a good thing. I thought we probably used too much bureaucrat speak, but we tried to say this is a good thing, everybody should get it. A couple years later, I come to Aledade and I go out to one of our practices, and we've been coaching them on targeted annual wellness visits, do more. We're measuring them. They get a letter from CMS saying, you're an outlier, too many annual wellness visits. I was like, oh God, what have we created? So we had to go to CMS and say, remember, this is the thing we wanted them to do, but and CMS agreed, to their credit, and we've never, they dialed that back, but the whole structure was built around a fee-for-service mentality of, we're going to keep an eye on you. Whereas, that's why we need to break out of that mold.
Yeah. And so talking about value-based care, and this is not on our question list, so we're going to, but I wanted to get at with you, when you implement value-based care, one of the key components of that is measurement. And so I'm going to go there and talk a little bit about measurement and the challenges therein. Certainly for primary care, there are a significant number of measures that can be used to assess the value of primary care. And that is another layer, I would say, when we get to frustration and burden at the practice level with regard to a variety of different measures being used by different payers. Whether they're Medicare Advantage, plans, or Medicare itself, or other private payers for other patients in their patient population. And so I guess, and I know we have a lot of work that's been going on, obviously, to align across different payers on this front. But I mean, from your perspective, where do we need to go to improve the approach to measurement of primary care in value-based models?
I was hoping you'd ask this question. I just came here from 2 days with 10 of our market teams doing updates about how they're working with their primary care patients. So probably a third of our total primary care patient population represented by the clinical and operational leaders we met with in the last 2 days. 500 pages in the deck, half of it all metrics. And in a way, I was really proud to see the precision and the focus. Here are all the HEDIS metrics. Here's where we stand by the end of Q1 going into Q2. I love the commitment our teams are showing to trying to move the needle on engagement, net promoter score, preventive and chronic care quality rates. And then sometimes I take a step back and say, we're focusing a lot on the middle, and we're probably missing some things on two ends of the equation. One end is, what do people really want from their primary care team? Trust, access, we all know the 4 C's. You can argue if it's 5, you can pick your version. There's patient-centered metrics I know that groups in the room have helped to sponsor and are writing about. That feeling of being cared for. Isn't that what we all want? We don't measure that. Maybe we can't measure it. Maybe we need to look at it indirectly, because if we measure stuff, we sort of squash it a little bit sometimes. So that's one end of the spectrum, which is, what is that relationship meant to be, and how do we just kind of simplify and keep the focus on that? Because I'll tell you what, no one else is totally thinking about that in the healthcare ecosystem beyond NPS. So we need the depth, we need the support in primary care to look at the relationship, the continuity, the trust. let alone disparities that have existed for a long time in communities that would understandably need some added kind of engagement and care and support and a different equation to kind of reactivate that. The other side of the equation is outcomes. I think this is another benefit of working already in kind of a full risk world, which is when you look at our current quality metrics, what is there really about outcomes? And so I think we need to radically move to the two sides of the equation and ask ourselves, is people's health actually better in aggregate or at a condition level or episode level? That's what we think about in our model. We want to understand whether we're overprescribing medications or have our patients who are old and frail and have too many conflicting factors on medications they shouldn't be on with too many unintended consequences. We want to look at if they're getting a hip surgery because they fell and emergently got taken to the ER overnight. Is it done in an age-appropriate risk stratification way? Is there consideration about their morbidity and frailty, about what happens after and the shared decision-making? These are all things that are not really looked at on the outcomes side that would be very person-centered and very outcomes-focused. So I think we're doing a lot of stuff in the middle. The universal foundation that's been proposed would be very helpful for everybody who's working with multiple payer segments just to have some simplification. But I think we need to pull to those two sides.
Yeah, I'm glad you mentioned the Universal Foundation because CMS announced this big initiative to try to create cohesion across programs, and I think with the private sector as well. And it was music to our ears, with the caveat that we've heard it before. There have been previous efforts that were not entirely successful. I do believe the current efforts are sincere, and we're going to contribute as much as we can. The example I always give, because we try to get our practice's entire patient panel in value-based contracts, they could have Medicare shared savings, multiple MA plans, a Blue Cross plan, and multiple Medicaid plans. And I've just described the situation of a practice for Aledade in North Carolina. So 4 or 5 Medicaid plans, 3 or 4 MA, Medicare shared savings, and Blue Cross North Carolina. There's a couple of practices in North Carolina because are measured and paid on 46 quality measures. And if anybody thinks they're focusing on performance on 46 measures, you could cut that in half and the practice still couldn't focus on 20 some measures. So I think we have to step back and say, well, what is the purpose of quality measurement? It's really important. Like, we had a movement to capitation back in the 90s. Part of the problem was it was solely about controlling costs and not about improving care. So you do need a quality measurement focus, but it has to be more meaningful. 2, what's a realistic number, and what are the most crucial areas for these primary care physicians to intervene to make a difference in the life of the patient? And you can use other measures to monitor, not necessarily to judge, but are our payment models working? Do we need to worry about a set of providers? But they don't have to be the measures that the primary care practice is paid for. The Medicare Shared Savings Program, we give them a lot of credit. They've started focusing on the core ones, A1, the hypertension, A1Cs, those sorts of things, and really have restricted the list. But others haven't followed suit, and we don't have the consistency across payers.
Sean, you went where I was thinking too, with regard to the importance to practices of using QI measures internally to monitor what matters to them and their patient population. But I don't think that they get credit for that, really, when you're looking at a broader payment system that is counting how you're doing on these measures. And that, I think, is an ongoing challenge, is having not when the practices are able to identify measures that matter to them, it doesn't really translate into what gets paid for or publicly reported. So I think that's an ongoing challenge, that there are ways we can think through how to layer that in to value-based models, the sort of credit or whatever you want to call it for doing that internally, and taking that initiative would be really, really helpful. And even taking on, broader QI projects, programs, et cetera. So one of the reasons why I brought this up is because this and, dealing, and I appreciate what you said, Sean, about having a practice, even 42 measures having too many, contributes a lot to burnout among the physicians and their teams taking care of the patient population. I mean, what do you think that Medicare can do? What sort of, Medicare, honestly, a lot of Medicare policies, quite frankly, contribute, as we've talked about, to that burnout, to the lack of professional satisfaction. And we know that this was compounded during the pandemic. What can Medicare try to do to think more innovatively about how they can address burnout and professional satisfaction among those practices that are providing care to the Medicare patient population?
Well, in the field of primary care in particular, I would say there's two things. One is, so the biggest problem our practices have is day-to-day. Like, they're not getting paid enough and their revenue streams are not certain enough to just know that we'll be here 6 months from now. So, we've, I think, long advocated that the fee schedule. So I often say, like, if the Medicare fee schedule, undervalues primary care, and then you're getting a low percentage of that, like, the problem is both with the payer and with the fee schedule. So Medicare can do its part, enhance the fee schedule. I give CMMI a lot of credit. They keep trying these different primary care models to enhance payments. The problem with that is, in the CMMI context, it has to be budget neutral at least, and they've struggled to meet that. Whereas I'm saying, no, just pay them more, so that they have the certainty that they can survive. That's basic one. Remove the stress of simply existing. Then, and I'm a bit of a proselytizer about this, the move to value-based care. I do think with the proper support, primary care physicians in value-based care, if they're supported properly and they know they can meet their regular expenses, they are shifting to a form of care that seems more like morally consistent with what they wanted to do, what they thought they trained for, what they thought medicine was about when they went in to primary care. The reason they gave up on all the wealth of the subspecialties was for a type of model of care that I think value-based care gives them a pathway toward. So I think CMS, and they've done elements of this, really support at a basic core level better primary care, and then they've done this, give multiple pathways to move to value-based care, so that we're not the only ones out there. There's the room's full of organizations, including Humana, that support primary care in moving to a better form of care.
Just to build on what Sean's saying, we did a time study in one of our teams last fall of how our PCPs were spending their time. And I will tell you, every time you do a time study of a primary care team, you are shocked, disappointed, and feel like you're not doing a good job as a leader, which is what I felt. Because our clinicians and all their supporting partners in the team are imprisoned by the technology and overburdened by the tasks. And if you go to a high-performing specialty group, they have the margin to staff their team to organize around the work and handle it effectively. And I'm not saying that's a bad thing. I think it's a great thing. If you go to an orthopedist, and they often have a PA or a NP with them, a very highly skilled person who can actually do most of the assessment and follow up with you, and they sort of check the plan and make sure you're going down the right path. But all of that is task shifting and management that requires staffing. So the first part is we have to reduce the task load on primary care teams through administrative simplification, better technology enablement, because the technology is not built for clinicians and practice. I've never seen an EMR that actually shows the clinician what they want to see in the first screen. If it exists, it's definitely not the ones that are scaled yet. So that's one part of the equation. Another part, which came up earlier, is around the workforce development. And I think to some of your comments, Sean, a lot of the people who are intrinsically oriented around working in medically underserved communities, serving people with multiple needs, whether they're younger, middle age, or older, they have loans. And so I think what the government has done through loan forgiveness has been really important. And I think we need to expand it around the type of work people are doing, less whether their organization has a certain tax categorization or not. Because it's the same people trying to work in the same areas, and we're trying to raise all boats. So as long as they're doing the work, maybe we should take away that huge cost we've made them incur to follow their passion which is sometimes hundreds of thousands of dollars on loan support needed. And then the tough decisions they have to make to try to do what they trained to do, but also not impoverish themselves relative to what they want to do for their families and their income over time. And I don't know how many of you are on Twitter, but I follow a bunch of other clinicians on Twitter. And over the last year or two, people have been posting their loan balance with public service loan forgiveness when their forgiveness is hit through. Literally goes from $250,000 to zero. And I think about what that means for that person who spent years training, whether they're a mental health professional, a physician, a nurse practitioner, care management nurse. I just think we need to do more of that for the right work, for the right roles in the right areas, and get rid of a little bit of how we've categorized it right now. And I'll say that we need to make having a role in a primary care team the job people want, the thing that's on the billboard when you drive into town, the people you meet during training that you spend time with, and a job of prestige again. And Sean, you gave the comment earlier about one of your comments made me laugh, because when I told my father, who's triple boarded and a private practice practitioner, just retired last year, and he's done primary care, pulmonology, critical care, he was sort of across all sites for 30 or 40 years. When I told him I was going to primary care after I finished residency, he was like, the phone call ended pretty quickly. God bless him. Then he talked to his buddies, cardiologist who was chief of staff at the hospital, who's practiced that for 30 years. And then he forwarded me a week later a note from one of them, basically questioning my whole decision-making. So there is a bias and stigma about becoming a primary care professional in our current environment that I don't think we talk enough about, that we have to challenge in the broader healthcare ecosystem and create real avenues for workforce development and prestige and respect. It's not all about money.
If I could follow on with one small point, you mentioned the loan forgiveness, which I think is hugely important. And the current loan forgiveness programs are, I think, appropriately, historically structured that to get the forgiveness, you have to go into a federally qualified health center or, some nonprofit, a health system. But things have changed in the world, and you can't get that if you go to a rural area and set up your own office. So you're in a health professional shortage area, you're not working for the hospital, you're just willing to serve an underserved community. That alone does not qualify you. So I think that the terms of which loan forgiveness could be broadened to reflect the realities of the needs of the health system today, as opposed to back when these programs were created.
Yeah, and I think that's an important point. And you all are both getting at the issue of finances for physicians and their practices. And one of the things that I think came up on the morning panel was the fact that a lot of physicians are going into employed arrangements or into, for a variety of reasons, or, into an entity where they may not be fully employed, but are operating under a larger system. And one of the challenges when we get into value-based payment is that payment may go to an entity, but it doesn't get to those that are actually on the front line providing primary care. And so I guess I'd like to hear a little bit more from you all about how we can better facilitate that within models, within Medicare in particular, but within models more generally. How can we ensure that those that are on the front line providing this care to the patient population are seeing the rightful fruits of their work in terms of the financial reward that may be coming to that entity for value-based care?
And I apologize if I'm returning to a theme too much, but I do think value-based care is the root, because what you pay for shows what you value. And right now, whether you're the health system or the society or payer, we're paying for subspecialty care. So implicitly signaling very strongly to the world, that's what we value. I do think, and those of us who've been in value-based care for a while realize that starts to turn this thing on its head, where the subspecialists become a cost center, not the source of value. I think we have a long way to go, but that would start to put the primary care physician. There was an insight that led to the creation of Aledade, which is if you had 100 PCPs and they each had 2,000 patients, basic, regular panel, and each patient, spent in a typical year $5,000, which is a mix of Medicare and commercial. That's $1 billion of spending being influenced by 100 PCPs. Now, is society currently reflecting that these 100 PCPs are like so important that we've entrusted them with $1 billion of spending? No, I think just the opposite. Because in the fee-for-service world, most of that money is downstream. But in a value-based world, we align the beneficiary with the PCP. So the first step we say is the PCP is in charge. So I think this is going to take evolutions of value-based care. We're not there yet. But anything that recognizes the primacy of primary care, the importance of it, the fact that primary care is in charge of billions of dollars of downstream spend and reflects that, I think it will then seep into the medical schools and the specialty training and saying, oh, you're going to be the general of $1 billion of spending. You'll get a nicer note from your dad.
It was his friend.
Oh, his friend, yeah. But I know your dad only passed it along because he felt it.
Yeah, that's true. Yeah.
So we have to, it's part of the inversion of the current system. And, we've had pockets of it, but we certainly haven't had a societal change that we need.
I'd say, I think primary care is becoming more competitive to recruit in. That's been a very active trend in the last 2 years. We talk about this a lot with our recruiting team. In the first year or two of COVID, their sentiment was people wanted to hunker down. They wanted to take a risk as long as the environment was okay. In the last year and a half, I think there's a combination of factors, some of which are good, some of which just are. The good are, I think there are more options for people so they can negotiate for better pay. And so we're proud of what we pay our primary care clinicians. We have a robust bonus program. It's focused on some of the metrics we talked about. People don't look at the bonus program and say, it's misaligned with what you're telling me this whole model is about. Could any of us support paying more, and should we pay more for primary care over time? Yes. But to Sean's point, we spend 5 to 7% as a country on primary care. And in Humana's full risk value-based care arrangements with groups, they end up seeing that something more like 15 to 17% goes to the primary care group. And when you look at international literature about developed countries with strong public primary care infrastructure or private primary care infrastructure, they're much more in that 15 to 17% range. So we are paying a third in aggregate of what we should at least have as a floor for primary care. And to your point, Jerry, there are many environments in which that does not even trickle down. It's not, let alone become an organizing dimension. So I remember an experience when I was coming out of training, talking to a big system in New York about a population health, kind of clinician population health role. They had an ACO, and I said, could I visit a practice in the ACO? It was not an Aledade ACO. And there was a sign on the front desk that said, dear patients checking in, you may be in an ACO with us. Please bring up and we can tell you whether you're in an ACO. Then I met with the clinical leadership and some of the clinicians, and I asked the clinicians, and I said, what's going on with this ACO? They said, what's an ACO? Patients didn't know they were an ACO. Clinicians didn't know they were an ACO. And so that's tangential to the financial part, but I think it's related because to create the focus of the model, the financial alignment to reward people for what's a very meaningful career and contribution to people's health, those all need to come together. So I think there should be more transparency about the framework in which we're asking people to operate and deliver care in, including salary. I think we need more competition to recruit the best and keep them, not less. And I'm saying something that's sort of against my own incentive in my role, but I think it's important for great people to enter primary care at higher volumes, sustainability of the field over time, and the contribution it can make to our society's health.
Yeah, and to build on that, I guess what I'd want to ask about is we know that there are significant disparities in pay related to gender. And I just wonder if you could speak a little bit to that in terms of, you talked about transparency in the investment going to the primary care physicians, whether that's, a salary or payment. Have your organizations looked at this at all in terms of the gender equity within your systems?
So at Aledade, I should have made this clear. We don't employ physicians directly. We are partner with the independent practices, and we're the transparency you want, we provide, which is when value-based payments come in, we give half to the practices and we keep half because all the services we provide them are free at the point of service. So we don't have a lot of insight into that, but I mean, certainly it's a societal problem, but we don't directly, we're not helping or contributing to the problem. So
I put you on the spot with this one.
We do. And so actually the majority of our primary care workforce are persons of color, 70+% across our national footprint. This is 4,000 or 5,000 people. And the majority, some similar figure, greater than 50%, are women. And when I entered medical school, it was the first time in my medical school where there were more women than men by a slight, like 0.5% or 1%. So I've seen female clinicians run codes. They've been my doctors. I've reported to them. They're on my team. And so just reflecting on those experiences, I'm very happy that our human resource strategy and framework includes a checkpoint, because we all don't know our own biases. And it's important to get the self-education and kind of question your own decision-making. But these are micro decisions that happen in, what do I make that initial offer? When I'm looking at raises, am I looking across the role and the salary bands? Am I gut checking it? Does it vary for the right reasons or not? And so you can have algorithms and all the rest kind of give you some signals, which we do, but then it's a human judgment with people self-calibrating and trying to ask themselves the hard questions. And as leaders in our team, we take that very seriously as well.
Thanks. I put you all on the spot with that one, but it's been on my mind lately. So what I want to do is shift gears a little bit. You all taught, I think maybe this came up earlier with PIRVA, is the issue of, primary care. It can't exist on its own. It's in a system, working with subspecialists, other specialists. And I know that she mentioned that CMMI is looking at models around this and how to ensure that the team, the primary care based team really works effectively and efficiently with the subspecialists, that many of these patients have multiple chronic conditions, seeing several specialists, and with that, whether you want to call it a quarterback, a left tackle, a point guard, whatever the term is. Are there efforts that you all are engaged in to try to ensure that integration with the specialty care practices with which the primary care practices are working?
I've made you go first a lot, so if you don't mind. So as the son of a specialist, a triple boarded specialist, I think of who are our BFFs in primary care. And specialists are one of our best friends. When we are working together with a patient, you have the text message, you've got the quick consult, you can get somebody in, they tell you what's going on, it's a shared decision, you decide who's on first with the patient, there's an evidence-based approach, and then you personalize it. That is fundamentally necessary and impactful for people's health. When it's fragmented in independent silos and you can't partner effectively on that, people get what they mostly get right now, which is tossed around in different perspectives and primary care unplugged from it, the people who know the patient the best, usually. And so people then go down kind of the train of cascades, to Dr. Ganguly's term, which maybe isn't in their best interests, but they didn't have a counter view or a shared view about it. So we are starting to do a lot more within our primary care group. I think community obviously does a lot around partnerships and the network, and supporting quality and highlighting quality among specialists and primary care clinicians. We'll be doing an implementation of a specialist e-consult platform, which I know is in CMMI's view. We are looking for better data and analytics about appropriateness of care, quality of care, and specialty-specific outcomes. So hoping to see that come through CMMI's work and some of the specialty care models they talked about, because it's not there right now. You've got to go try to work with vendors or create your own metric set. And it goes back to the quality metric conversation, which is you can get a lot of data about specialist cost, you can get a utilization, but is it the right stuff for the right people at the right time? And that's what I care about. And that's what our team cares about for our patients. And that's what we care about for our family members. We actually have a very small embedded cardiology group in one county in Florida. We have about 25,000 seniors we serve in Broward County. And when I joined the organization a little over a year and a half ago, I went down to visit, And I met an amazing cardiologist named Dr. Evan Jacobs, who I was now on the team with. And we spent like a morning together, and he told me about how his little practice is running. 2 or 3 people, they take all the cardiology referrals from our primary care group for those 25,000 seniors. They have the best avoidable heart failure admission rate in the country in our group. They know all the vascular specialists by name, all the interventionalists. They know what's happening in the cardiology suites in all the hospitals locally. So they are not just delivering amazing evidence-based specialty care within our 4 walls. They are also helping to guide the rest of the cascades and the network of care and curating it. And so we're looking at, could we expand that program? And are there other areas like that? But obviously you can only do so much yourself. So we need to work with the ecosystem and use data and have all of the same things we've seen in primary care, value-based payment, data enrichment, partnership models. We need all of that to happen in the most relevant specialties.
Yeah, so as Dr. Garg said, if you're in primary care, you've got relationships with a whole bunch of specialties. Like you couldn't exist without those. The abrasion, to use a term used earlier, comes when, for the primary care docs, fee-for-service is not working, both morally and financially. So they're pivoting to value-based care, the ones with Aledade. But for specialists, at least financially, it is working for them. And so how do you set up alignment of incentives between people who are choosing one model of care with a group who are happy with the current model of care? It isn't easy. We're trying a number of things. We're testing. We have a big enough network that we have the luxury of running tests around the country. So we're working with a number of the subspecialty consult vendors and testing them against each other, which has been really interesting. In some markets, we've had our PCPs, particularly in rural areas, do what we call care compacts, where they convene the cardiologists and explain, hey, we know you guys are in fee-for-service, but we're not. So here's how we want to work with you. And in smaller communities, that's worked actually pretty well. I don't know that it's a scalable model across the country, but we're trying a number of things. I really like what Purva was saying on the previous panel. I know, because I know CMMI has struggled with this very issue, but this notion of providing our docs with bundled data, sort of shadow pricing, showing what's going on with their patients, I think could be very powerful. And having a less regulatory approach, which is, in the past, CMMI sort of superimposed bundles on top of the ACOs, and we all argued about the pricing and whether it was right. But I think the information alone could be very powerful, and we might be able, we're talking about how we would use it to create specialty referral networks and that sort of thing. So there's a lot of action, but not a lot of improvement just yet, because there's such a lack of alignment of incentives.
So thanks. I think we are wrapping up. So I'm going to give you one last lightning round moment to say anything that you want to say to this group that you have not been able to put forward with regard to the importance of primary care in Medicare and what we can do to support primary care within the Medicare program.
That's a tough one. I think the question I have is, who else do we need to convince? I think we're all on the same page here. We're doing the work we're doing, and we're here for a reason. Let's marshal our action with those partners and bring them into the fold.
Thank you. Sean?
Let's value total person care, meaning the total experience the person has, cost, quality, and then pay appropriately for the people who can most influence that.
Great. Thank you. Thanks, everyone.